Hello, everyone. Thank you for being here, and thank you very much for the opportunity to present today. And the topic will be colorectal peritoneal metastasis, HIPEC, yes or no. These are my disclosures. We'll try to answer this question by starting with a little bit of a review of what differentiates peritoneal metastasis from other types of colorectal cancer metastasis, how that has influenced the development of standard treatments and the treatment paradigm and its evolution. We will then focus on the specific role of HIPEC and what data about it have we learned from a recent randomized controlled trial, how the results of this trial influence the current standard of care, and a little bit about future directions. So are peritoneal metastases special? I think our mental image of how they look certainly suggests so, as well as our understanding of the physiology of how they develop. In recent years, we have really begun to understand a lot deeper at a molecular level what are the mechanisms behind metastasis formation, both hematogenous as well as peritoneal, and we certainly understand that there are important molecular differences from the very beginning of the metastatic process as well as the end of this metastatic process and the interactions that happen at the cellular level between the malignant cells and the peritoneum. This certainly clearly suggests to us that the peritoneal space is both the target, but also the vehicle of metastasis formation when we speak about peritoneal metastasis, and has therefore really greatly influenced our therapeutic approach. And the standard treatment paradigm in the last 30 years or so has certainly been cytoreductive surgery and HIPEC as the standard treatment for peritoneal metastasis, including colorectal. And our talk today will really not focus on the cytoreductive surgery part at all, which is essential, but we'll focus on the HIPEC as an addition that we developed to target the peritoneal risk. This is an example of various HIPEC regimens that have been used in colorectal cancer, and we can clearly see that they differ in terms of the drugs they used, in terms of the doses, and in terms of the duration. However, there are several principles of HIPEC that are really common to all of these regimens, and that is the idea, which is rooted in pharmacology, really, to try and increase the peritoneal drug concentration, to limit the systemic exposure or absorption of these drugs, and to use the synergy with heat in an attempt to augment the cytotoxicity of the intraperitoneal drugs. And in the last 30 years or so that we use this treatment paradigm, we certainly have seen clearly how deeply it impacts the outcomes in colorectal patients with peritoneal metastasis, from the very first randomized clinical trial in the Netherlands Cancer Institute, which doubled the survival compared to systemic therapy, to then later larger multicentric cohort studies, which confirmed and improved on these results. However, what these studies really could not answer, because they always combined the use of cytoreduction and HIPEC, was the question of what exactly and how much does the HIPEC add to the surgery, to the complete surgical resection of metastasis? Does it add, and how much? And at what price, or how much specific HIPEC-related morbidity does it bring? So to attempt to answer the question, a randomized clinical trial was designed in France. The PRODIGE 7 trial was done to assess the efficacy and safety of HIPEC in addition to complete cytoreductive surgery for patients with colorectal cancer, peritoneal metastasis specifically. It randomized approximately 130 patients per arm to either cytoreduction followed by HIPEC versus cytoreduction alone. All patients had to have a complete cytoreduction, either CC0 or CC1, and they also had to receive 6 months of systemic chemotherapy. However, the exact regimen to be used, and the timing, whether pre or post-op or combined, was not strictly prescribed in the trial. It was left to the discretion of the investigators. It's important to note that the HIPEC regimen that was chosen was one, and it was the high-dose oxaliplatin 30-minute regimen. And the primary endpoint of the trial was overall survival. So what did the trial show? It was first presented in 2018 as an abstract, and just recently, a few months ago, as a full publication. And the results certainly are very interesting. First of all, the main primary endpoint, overall survival, did not differ between the two arms. It was 41 months for cytoreduction plus HIPEC, as well as for cytoreduction alone. So no difference between the two arms, but it is important to know that the survival was excellent, 41 months, and really much higher than the predicted survival in the cytoreductive surgery arm, which was hypothesized to be 30 months at the beginning of the trial. And that it certainly emphasizes the great importance that complete surgical resection in an expert center has when we speak about patients with colorectal peritoneal metastasis. The secondary endpoint was also no different between the two arms. Recurrence-free survival was 13.1 months in the HIPEC arm versus 11 months in the cytoreductive surgery alone arm. A bit of a trend, perhaps, of a slightly longer recurrence-free survival for HIPEC, especially in the first 18 months. However, no statistical difference between the two arms. However, what was different between the two arms was the morbidity. There was a higher incidence of grade 3 or higher morbidity in the HIPEC arm. At 30 days, this difference was not statistically significant. However, at 60 days, it persisted and it became statistically significant. So where does that leave us, and what conclusions should we draw from the results of this important trial? Well, the first and the most obvious conclusion certainly is that the high-dose oxaliplatin 30-minute HIPEC regimen should no longer be used. But however, there are other questions, a little bit bigger questions, that we are all interested in, and that is, does that mean that HIPEC as a concept is obsolete in colorectal peritoneal metastasis, or should we still consider using it and studying it in the future? I think this is the big question, and one that has a much more layered answer. And in order to look for that answer and to find it, hopefully, I think several approaches could help us. One is to analyze what factors influence the result of the PRODIGE-7 trial, and why did that HIPEC not work? Did we observe any trends that may inform us in terms of designing future trials? Are we conscious and knowledgeable enough about the landscape of colorectal cancer as a whole at the present time, and how that impacts patients with peritoneal metastasis, as well as keeping an open eye towards trends and new technologies in terms of peritoneal therapy delivery that also may help us realize a potential benefit of regional therapy in peritoneal metastasis of colorectal cancer? So let's first look at why was PRODIGE-7 a negative trial. There's certainly many places to look. I think the most obvious first is the regimen itself, and there's several specific aspects that are important to note about this regimen. First of all, the dose. This is a very high dose HIPEC regimen. The dose of oxaliplatin is 3 to 5 times higher than what we use systemically in FOLFOX, for example, and that certainly could have played a role in terms of the morbidity, one of the endpoints of the trial. Second of all, the drug itself, oxaliplatin, is not necessarily the biggest superstar in terms of its pharmacologic properties and the peritoneal to plasma AUC ratio. There's really very little or almost no data in animal models showing any benefit of intraperitoneal oxaliplatin against colorectal peritoneal metastasis, unlike some other drugs where that has been shown. As far as synergy with heat, there's also very scarce data on oxaliplatin and its synergy with heat, and the data that exists is contradictory in terms of whether that synergy exists or no. And finally, most patients with colorectal cancer will have prior exposure to oxaliplatin and therefore could potentially have developed some resistance by the time they actually receive this HIPEC, resistance to oxaliplatin. And then the final point is the duration of the regimen itself. This is a very short HIPEC of only 30 minutes. This short duration was really chosen as a pragmatic step to minimize the systemic absorption since the dose was pushed up very high. However, there is emerging data that clearly shows that the effect of intraperitoneal drugs is time dependent, and therefore a very short HIPEC regimen certainly could be simply ineffective because of this too short duration. The second aspect to consider in interpreting the PRODIGE-7 results, but also in designing future trials, is the study population, how we defined it. The PCI in this study, for example, was allowed up to an upper limit of 25, which is really quite high for colorectal cancer. And it is possible that patients in this high end of PCI, because they have an overall guarded prognosis, a very high risk of recurrence, both systemic and peritoneal, that their potential benefit of a regional therapy could be much harder to see. Also, the systemic chemotherapy aspect is important, but it was not strictly defined in PRODIGE-7, and that may make the interpretation of the results a little bit harder and perhaps should be defined more strictly in future trial in order to see a potential benefit of regional therapy. The importance of PCI as a definition or an inclusion criteria is perhaps suggested by this trend that was observed in this trial. Really, the only positive trend in this forest plot was that a benefit of HIPEC was seen in a subgroup of PCI, intermediate PCI between 11 and 15. So perhaps this is a suggestion that we need to think about including only some patients with peritoneal metastasis in future HIPEC trial. I think we have to be careful about over-interpreting this observation, but it's certainly something to consider for the future. And finally, the endpoints. This trial was based on overall survival as an endpoint. However, there are many factors that indicate that overall survival is really unlikely to be impacted by HIPEC alone in colorectal cancer. Despite the very good overall survival observed in this trial, we have to remember that these patients have a very high risk of recurrence. In fact, the 5-year recurrence-free survival in this trial was only between 15 and 20%, and that more than 50% of these patients will have a systemic recurrence. Certainly, the recurrence risk and the systemic recurrence has a big impact on overall survival, but it's very unlikely to be impacted by a regional therapy such as HIPEC. So, if we are to look for a potential benefit of HIPEC or similar regional therapies, we really may need to focus on different endpoints when we speak about colorectal cancer. In designing future trials, we have to take into consideration what we have learned about colorectal cancer in the last 10 years as a whole. We now know that colorectal cancer really exists as several molecularly defined subtypes. We know that certain mutations have a big impact on survival, and we also know that the MSI status has a big impact on therapies and on survival. We have not fully implemented this knowledge when we speak about colorectal peritoneal metastasis and how stratification and inclusion criteria need to be based on some of these factors. And again, these may be important ways to really find a potential benefit of local therapies. And finally, when we speak about targeting the peritoneal space for treatment of peritoneal metastasis, we have very much focused on targeting and sometimes perhaps respecting the peritoneum as a barrier to peritoneal metastasis. And we have targeted it basically exclusively in the form of HIPEC, which was based on three very rigid concepts that we have defined before: very high peritoneal drug concentration, hyperthermia, and low systemic concentration. However, it's possible that we need to reconsider and be a little bit less rigid about these concepts. It's possible that the benefits of local regional therapies in colorectal cancer will be shown by inverting some of these principles on their heads. For example, we know that hypothermia is positive when it increases cytotoxicity, but we also know that hypothermia can be damaging to the peritoneum, can induce heat shock proteins, which can be proliferative and allow cancer cell proliferation. It's possible that very high chemotherapy concentrations on the peritoneal surface also alter the homeostasis and the immune environment of the peritoneum and make it more vulnerable to malignant progression. And finally, we are well aware that systemic therapy is absolutely crucial in colorectal patients, and also the ones with peritoneal metastasis, and using regional approaches to deliver and target the peritoneum, but also deliver systemic doses. It's something that we really have not done in HIPEC, but perhaps could be considered in future applications. There are some new technologies on the horizon that really are based on different concepts than HIPEC. One of these is PPAC, that right now occupies a very different space in addressing peritoneal metastasis of colorectal cancer and focuses on unresectable cases. But we have to be open-minded about utilizing some new principles in terms of looking for potential benefit of regional therapies in peritoneal metastasis. So going back to our original question, do we HIPEC or not in colorectal peritoneal metastasis? I think the answer to the not part of the question is really quite easy. We will no longer use high-dose, short-duration oxaliplatin HIPEC. However, the answer to this first part of the question about HIPEC or potentially other regional approaches of targeting the peritoneum, I would suggest that we need to leave that door open a little bit longer. Certainly, there have been some recent examples of successful high-level studies, high-quality studies that looked at the benefit of HIPEC in addition to cytoreductive surgery in a number of different diseases and shown a benefit in ovarian cancer, in gastric cancer, in PMP. So my suggestion is that we keep that door open and that we keep looking, because it is possible that we still see a bright horizon ahead. Thank you very much for your attention.